It's another beautiful Friday on Impact, and as usual, between you and I, we'll do our best to talk our dear country into shape. Today on Impact, we'll be taking a look at the health sector. You and I are familiar with that scenario where you're very sick and the one place you want to head to is the hospital. And when you're in Nigeria, most times getting to the hospital might actually do less for you than being at home and knowing that you are still without medical help. Sorry to say that in some of our hospitals, the medical care personnel are something else. You could get to the hospital, the treatment you get is harsh, you're treated as though you ought not to be there, and all of that. What is being done to put in place a medical health care system that will cater for our needs and still treat Nigerians with reverence? Now we have our doctors going on strike every now and then. What is being done to make sure that whenever you get to the hospital, there will be a doctor on call? What is even being done to ensure that the person you're going to meet on call is equipped and in the right position to deal with your ill health? These and more are what we'll be looking at on today's edition of Impact. I have here with me today in the studio to take a comparative look at the healthcare system in Nigeria and in other climes. Neurosurgeon is a professional, and he will be taking a look at our healthcare system vis-a-vis healthcare systems in other parts of the world. I'm talking about Doctor. You're welcome on the program.
Thank you very much, Francisca, for having me.
Now let's look at the big picture. 56 years after independence, we've had the leadership of the healthcare sector resting in the hands of Nigerians. From your assessment, how well do you think we've done?
I think basically the word that we use is we've struggled so far, looking at the last 56 years and looking at the supposed progress that we are supposed to, that we should have made, that we have not made. So basically, we've struggled.
Okay. Now, there are some people of the opinion that always the Federal Ministry of Health should be a medical person, or somebody at least who is into the field of medicine and sciences. Now, to what extent do you think that not having such a person in place has affected the medical system thus far?
I think probably the question you're trying to ask me is that who should be the ideal minister for health? There are a few things. Number one, if you have a minister of health who has a healthcare background, it's a plus, but not a must. Okay. So, what are the key things that an individual needs to be the minister for health? Number one, it must be someone who is well respected, someone who is passionate, and not just passionate in words by saying, "Oh, I'm passionate." No, you can actually look at the track record and see that this person has done work within healthcare at different levels and grown up within the healthcare space. The other key thing is that he must be somebody who is a good leader, a leader who understands the importance of collaboration and partnerships, a leader who can interface with other ministries, departments and agencies as well. For example, I cannot see why the Federal Ministry of Health and the Federal Ministry of Information, the Broadcasting Organization of Nigeria and stuff like that are not interfacing with each other, especially when it comes to massive advocacy for healthcare issues in Nigeria. Definitely, the Minister for Health must be a Minister for Public Health, which is so fundamental. And when I talk of public health, it must be someone who has an innovative mind, especially when it comes to trying to pass information out there in a strategic way to the average everyday Nigerian. What am I trying to say simply? Whenever it should be a minister that communicates in such a way that even the market woman or the Okada driver understands the healthcare issues.
Okay, now you're talking about interfacing with other ministries. Now, even within the healthcare system itself, we've had issues of division between the various sectors. For example, sometime past there was a strike by a particular sector of the medical doctors, and what we've got to hear is that, well, it appears that everybody who is not a doctor but is in the healthcare system is not treated the same as those that are medical doctors. So there seems to be even this division within the healthcare personnel. To what extent do you think this is affecting the quality of healthcare service we are given vis-a-vis collaboration between them?
Francisca, there are fundamental issues here. Number one, in Nigeria, we run what I describe as a rent economy. A rent economy means free money. We didn't put the oil in the ground. You understand? Even for many years, we're not exploring the oil and stuff like that. It's just recently that you have local content within the oil and gas industry. So with free money, what happens is that if you have a particular group of healthcare providers running the shows, i.e. at professional leadership level, at administrative leadership level and clinical leadership level, i.e. the doctors, and doing that for 30, 40 years, and then them getting more of the free money, it will definitely come to a point where the other people will say, in local parlance, now only you will a job. So it's simple. That's why we've got into where we are. There are problems with the organizational structure at all levels of healthcare in Nigeria. So if you combine free money and some particular people just are seeming to be getting the major share of the free money and poor organizational structure, especially with the unitary style leadership we have in different healthcare facilities, what you will get is what you have now. You will have some people becoming disgruntled and saying, oh, we want our own share. So that's what has played out now. So what you see with all other healthcare professionals combining together to form what we call Johesu, and them always attacking the doctors and vis-a-vis, that's what is playing out.
Let's get down to the issue of financing. If you go to some of our hospitals and clinics, and especially the government-owned hospitals and clinics, it would appear that comparatively what we find in civilized climes, that we are several years behind. Now, do you think that enough money is being put into the health sector, as it were?
Francisca, there's a fundamental issue of value for human life. And value for human life is a political issue. Okay? Now, because the healthcare sector has not been put in the mainstream as a major political issue, it is always relegated to the background. Okay? So that plays out in everything that has to do with healthcare, especially even financing. Financing is like the key in terms of trying to provide materials, human resource, and stuff like that. So we talk about what we call the Abuja Declaration of 2001, where all the African countries came together in Abuja, the heads of state and stuff, and then they discussed about funding for healthcare, and they came to a point where they said that they have to start working towards a point where they have 15% of the budget going to health. Now we know that we're struggling. This last budget was just about 4%. Now, so there are a few issues here. Number one, poor funding. Number two, even the funds that are available, how are they used? Number three, I go back to organizational structure again. We run the unitary style leadership within most of the healthcare facilities, especially the tertiary and secondary facilities. What does that mean? Let me try and break this down. So for example, if you are working in the theater and you have your clock in the theater and the battery gets spoiled in the clock, do you know that you have to raise an invoice for that small battery, go to the chief medical director and the key people at the top before they now vet it and stuff like that? Does that sound efficient to you?
For a battery of like $50?
Exactly. Does that sound efficient to you? You cannot run an organization efficiently like that until you devolve autonomy or you devolve the processes down the way, where you actually have at sub-units, you actually have people controlling a major part of their processes, their finance, their budget, and most of all the other processes. And those are some of the other problems that happen even with the different healthcare professionals fighting. I'll give you an example. For example, you look at the medical lab scientists and the pathologists who are doctors. There's lots of fights between them. Why? Because the key issues of things like managerial accountability, clinical accountability, lines of communication, lines of management are not well structured and people don't understand them. For example, a medical lab science unit that is being run well and they can actually control a major part of their budget and stuff like that should be able to employ medical lab science interns, for example. They should be able to source for their own reagents for the lab and stuff like that. At that level, they should be able to take control of the training and retraining of most of their staff. And that should not be the business of the pathologists who are doctors. So when it comes to managerial accountability, they should hold sway on their own. But when it comes to clinical accountability, i.e., talking about decisions for a patient, when it comes to lab results and stuff, they should be clinically accountable to the doctors, i.e., the pathologists. So those are some of the major problems we have with our organizational structure within the facilities. But financing, very poor. Use of the finance in terms of efficiency and effectiveness, very poor as well.
Now, you talking about the issue of the value for human life brings us to the point of how we manage emergencies in this country. Mm-hmm. Now, you see somebody at the point of death being rushed to the hospital. Probably an accident victim by the roadside is helped by somebody and taken to the hospital, and then you are asked to deposit money before treatment can commence, as though you have this budget for your purse that you carry about, hoping to find somebody at the verge of death. Now, this value for human life, does it not include also the medical system being able to respond in emergencies without asking for funds?
Absolutely, you're absolutely right. It's a value for human life issue. Okay. Now, the key thing here and the problem is about leadership understanding that value for human life and projecting it, and that's actually cascading down into everything. During the present, we actually have what we call the National Health Act, which is a law which was signed by the former administration just before they left. Now, in that law, it specifically states how emergencies should be treated. And like you rightly said, any emergency should come into a hospital, whether private or public, right, and should be dealt with ASAP, immediately, before asking for money. Okay? But that is not the case. Because when it comes to even the implementation of the different things, the different issues within the National Health Act, you can see there is lack of political will and lack of leadership to actually push these things through. Okay, it's a very good document. Usually we have very good documents, policies, acts, laws, legislation. There are many of them around. Translating them to reality on ground has always been a problem because of that lack of that oomph in leadership. You know, so those are the major problems. I remember using, for example, an example that one of the hospitals in the southern region in Nigeria, there was one of the chief executives of those hospitals that actually started a program where anybody who comes into the hospital, they actually go through the hospital, the patient goes through the journey, and it's at the end of the day that they actually collate everything that the patient and family are owing, and then they actually sort things out there, and it was worked fantastically well. But there's always the problem of continuity. When he left the seat, another chief executive came in and scrapped it. So sometimes when you look at some of these, they're actually good examples that you can use and stuff like that and try and scale up. But scaling up needs leadership that's committed and passionate.
We have tried to implement the issue of health insurance schemes. We have HMO providers and all of that. How well do you see this working out in the Nigerian sector?
Definitely, in 2016, universal health coverage is definitely the way to go if you want to get real traction and actually get most people in, especially for things like what we call like the basic health needs. One of the major problems in Nigeria is the issue of restructuring, is the issue of trying to devolve power and devolve processes down the line to the states or to the regions or to the local governments or whatever name we want to give it to. Now, you have the National Health Insurance Scheme. Do you understand? Most of their, how will I put it, the main office or most of the work that they do is here in Abuja. If you go to your village and ask, do you understand, your grandma or somebody who's in the village, they don't have a clue about what National Health Insurance is all about. So there are issues with strategic communication and trying to make these issues, trying to explain to people in a simple language, even using local languages and stuff like that, to try and pass this information about the benefit of having such a social health insurance scheme. And we have the new man, Professor Yusuf, who's really passionate about trying to take the National Health Insurance Scheme to the next level. But like you know, with the Nigerian factor, what we call the Nigerian factor, there are massive limitations of him definitely being passionate about how to actually take things across. Now, looking at figures, from the latest that we heard, definitely in terms of capturing, looking at the population of Nigeria, 180 million people, the National Health Insurance Scheme presently doesn't capture more than 5% of the population. So when you talk of the traction that it's had or the people that this program has been able to capture, very, very, very suboptimal. We are nowhere. At least when you compare ourselves to countries like Rwanda, who have done fantastically well. The fundamental issues of leadership again, of being able to work with the right, of being able to devolve the autonomy down the way, so that if you have the regional offices, for example, the National Health Insurance Scheme, that they are really working, that everybody doesn't just pander and wait for until Ogar the top, Professor Yusuf talks, then we can't do anything. So these are some of the key issues. Strategic community, we need to, the people within leadership, either at the Federal Ministry of Health, the state ministries of health as well, every medium, including a place like ITV, you understand, to really push out this information there so that people can actually know the benefits of being involved in such a scheme. And one of the key things about the National Health Insurance Scheme, it must be made mandatory. If you say, oh no, it's not compulsory, it's just anybody, no. For example, in the United Kingdom, because I just returned from the United Kingdom about 2 months ago, it is compulsory. Everybody pays national insurance. Everybody. Because healthcare is a key priority. Because in countries where they understand the value for human life, and they know that healthcare is about life and limb, healthcare is a major priority. So, going back to the issue of value for human life again.
Now let's talk about regulation, because some of the things that happen in the health sector, in the hospitals, in the clinics are downright unethical. You would agree with me that the medical profession, being one that handles human life, is one that should have a lot of ethics attached to it. Now look at the issue of regulation. Do you think that we have a proper regulatory body in place and that is actually functional for medical health practitioners?
Francisca, regulation, key issue. But I'll add to that as well, standards. You know, the key things about regulation and standard. We need robust regulatory framework and mechanisms within our healthcare space in Nigeria. So you look at the Medical and Dental Council of Nigeria, you look at the Midwifery and Nursing Council, you look at the Pharmaceutical Council of Nigeria. These are regulations, but there are others that regulate the radiographers, other healthcare professionals as well. Where are we with regulation in Nigeria? We are struggling. When it comes to regulation that is really strong, you know, regulation that more of protects the people than wanting to protect the profession itself, we are struggling there as well. When it comes to the issues of using technology to leverage, you know, and help to take regulation to the level where we should be in 2016, we are struggling. Go look at the websites of some of these regulatory bodies that I've talked about. Really pitiful. Okay? What you expect that, if you want, for example, let's look at the medical doctors. You expect that, you should be able to get onto the website of the Medical and Dental Council, and then even when you're seeing the doctor, you can type the doctor's name in there and see who the doctor is and where the doctor, and if this person is actually a doctor. Okay? So when it comes to regulation, we are struggling. Even at the state level, at the other sub levels, the state level and local level, we're also struggling, because when you talk about standards, because that's another important thing again, there are 3 levels of care. There's primary level care, secondary level care, and tertiary level care. So we're not just talking about even the public